They should be here, Dr. Asim and Dr. Abdullah. They didn't show up yet, but they will be here in just a minute.
Yeah, hello. Hello, everyone. Can you hear me?
Okay. And Dr. Abdullah is here as well.
So hello everyone, welcome to the Zoom meeting. And today we will have a couple of topics, and Dr. Haifa and her team will be presenting. And if we are ready, we will start. I'm gonna hand it over to Dr. Haifa, and your team, you can start when you are ready. Thank you.
Yeah, hello everyone. Thank you for being here today. I'm excited to welcome you to our session. First, I want to take a moment to sincerely appreciate the effort of all our presenters. Despite their busy schedules, they have shown great commitment and work hard to prepare a meaningful and insightful, valuable content. I would also like to give a special thanks to Dr. Hind and Dr. Awala, who had both expressed their willing to contribute to this session. Unfortunately, due to a last-minute personal issue, they couldn't be with us today. We are especially grateful to Dr. Asim for stepping in to present Dr. Hind's part. I think we can start with, we can start with Dr. Asim and Dr. Abdullah, who will be sharing valuable insights on dementia. Dr. Asim, if you are ready, you can start.
Yeah, thank you, Dr. Haifa, for your kind introduction. Now I am going to share my slide. Can you tell me if you can see my slide now?
Yes, we can see. Yes, we can see your slide. Yep.
Okay, perfect. So, hello everyone. My name is Dr. Asim Eisa. I am part of the Silver team. Today I am going to present a topic about dementia. And I am going to present in the behalf of Dr. Hind that she is unfortunately she cannot be here with us today. So this is the quick overview of our objective today. I am going to talk about the definition and the epidemiology of dementia, also the classification and the risk factor. Then I am going to talk about the major forms of the dementia and their associated clinical features. And also I am going to touch on the differential diagnosis and diagnostic approach, and also share with you some common forms of cognitive screening assessment for the patient of dementia and the benefit of the early diagnosis of dementia. And lastly, my teammate, Dr. Abdullah, will talk to you about the staging and the treatment of dementia. So, dementia, it represents an umbrella term that usually describe a collection of brain diseases and their symptoms, which include memory loss, impaired judgment or personality change, and difficulty in performing daily tasks. So dementia is not a single disease, but rather a collection of the many symptoms.
Yeah, Dr.
There are
Asim,
common diseases associated with it.
Yeah, we couldn't see the next slide, so we just see you are still in the first slide of the topics.
Objective.
Yeah, the headlines of the topics that you are going to present. So if you could change the slide to the next slide, please.
Okay. Can you see it now?
No.
Now I am on the second slide. It is not appear well to you.
Now you can see the first slide, the one that with the the very beginning slide.
Okay, I'm sorry for this technical issue. I am going to stop
No, it's okay.
sharing
Take
and
your,
then reach.
yeah, it's okay. Take your,
I share.
yeah, okay.
So what about now?
Yeah, now we can
It's
see it.
okay?
Yeah, now we can see it. Thank you.
Okay. So as I was talking, dementia is a collection of the symptoms rather than the single diseases. It can present with uh, symptoms like memory loss, impaired in the judgment and personality changes, and also the patient have difficulty in performing the daily task. There are many diseases associated with dementia. The most common is Alzheimer's disease, which represent about 60 to 70% of the causes, followed by the vascular dementia that represent around 20%. And then we have other less common forms like the frontotemporal dementia, Lewy body dementia, and other forms of the dementia that we are going to talk about. Regarding epidemiology, it is a very widespread disease. It usually are around 50 million people diagnosed and live with dementia in the globe, and also about 10 million new cases usually diagnosed per year uh, associated with dementia. So dementia is a widely spread disease around the world. Also, the dementia, it can be classified according to the several factor. First, it can be classified according to the underlying cause, which is the main classification. Alzheimer's disease represents about 60% of the cases in this classification. Then followed by the cerebrovascular disease, as we mentioned, that can arise from the problem or issue or damage to the blood vessels, like the multi-infarct or stroke. And also there is neurodegenerative dementia that occur in the diseases such as fixed disease, Huntington disease, or Parkinson disease. Also, dementia can be caused by infection, most commonly by infection called Creutzfeldt-Jakob disease, and also can be caused by HIV or acquired immune deficiency syndrome, encephalitis, or the progressive multifocal leukoencephalopathy. And then we have the reversible causes of dementia. This is represented in the normal pressure hydrocephalus, the nutritional deficiency, mainly the thiamine, but it also can be caused by B12 or folate deficiency, and also can be caused by metabolic problems such as in the disorder in the liver or in the thyroid and parathyroid gland or the adrenal gland. Also, it can be caused by other chronic inflammatory conditions like multiple sclerosis and vasculitis with different style. Also, dementia can be caused by trauma, mainly due to the severe form of the head trauma that usually lead to loss of consciousness of the patient. Also, it can be caused by tumors, like mainly in the frontal region of the brain, such as the subfrontal melanoma. And we have to note that around 10 to 15% of dementia causes are reversible. So it is beneficial first to rule out the reversible causes of the dementia before diagnosis can be achieved. Lastly, we have what we call normal age-related memory change, and this is occurred naturally due to the increase in the age of the population. Okay, also we have another classification of dementia, and this is according to this location. It can be in the anterior part, also it causes frontal premotor cortex in the brain, and this one is associated with behavioral change and this inhibition. And it can occur in the condition like the normal pressure hydrocephalus and Huntington disease. Also, it can be in the posterior part, which mainly in the parietal and temporal lobes. It can be present mainly in this part with cognitive issue like difficulty in memory and disorganized speech or language. And this is mainly present in the Alzheimer's disease. Also, it can be present in the subcortical and cortical area. In the subcortical, it can present with apathy, forgetfulness, and other movement disorder. And this is mainly related to Parkinson's disease or acquired immunodeficiency syndrome dementia. And we have the cortical dementia that mainly present with dysphasia, nausea, or apraxia, which patient here we have difficulty in the repetitive sequence movement in and other movement disorder. This is mainly occur in the Alzheimer's. There are multiple risk factors that can cause dementia. The most common risk factor is age. The incidence of dementia is approximately double every 5 years after the age of 65. So it increases as the patient age increase. Also, we have the family history and the genetics component. But the genetics component is rare causes of dementia, and it needs to be combined with other lifestyle factor and environmental change to cause the dementia eventually. There are a number of gene discoveries that increase the risk for the Alzheimer's disease, such as the PS1 and PS2 genes. And also we have the FTDD17 genes that can lead to loop type of dementia. And this can affect the normal process of the brain proteins. The family history increases the risk, but the familial forms, as I said, is very rare. So it has to be a combination of genetics and epigenetic components, and it is usually occur very early, 40 years old. Additionally, we have gender as a risk factor. Mainly, the female mainly can cause Alzheimer's disease, can be caused in female, and then there is a vascular dementia more related to the male and the female. Also, we have the high cholesterol level, and we have recent studies showed that the increase of dementia is associated with increase of the cholesterol level in the blood, and this is linked to the underlying biological process in the cellular level that can lead to dementia. And then we have the head injury and anesthesia. Some study indicate that head trauma, especially with the loss of consciousness and anesthesia, may represent risk factor in the vulnerable individuals such as the elderly population. So the risk factor about 65% are related to the genetics and age, and the other 35% of dementia risk, it can be within our control. So the healthier you are, the less influence factors like genetic and age. But you have to control things like smoking, the physical inactivity, and also the social isolation and the obesity, which has a minor contribution to overall appearance of dementia. Now I'm going to talk about the major cause of dementia and their associated features. First, we have the normal age-related memory change. This is mild memory decline. This typically occurs with the aging process. This usually takes more time to develop, and there is effort to recall new information. It doesn't intervene with the daily functioning, and but the new learning process will become slower, but it's still possible. It's often well managed using methods like list, calendars, or the reminders and memory aids method. Alzheimer's disease represents the most common form of dementia, about 80%. In the early sign of the Alzheimer's disease, there usually symptoms like memory loss, apathy, and eventually can cause depression. But the later sign occur as impairment judgment, disorientation, and the issue during the speech or the swallowing. There is histological dementia that represent in what we call the amyloid plaques, the tau tangle or neuronal loss, like we can see here in the picture on the right side. And here also a picture represents a healthier brain, and on the right side, this is the picture of the brain with the severe Alzheimer's disease due to the atrophic change. Then we have other forms of dementia due to cerebrovascular issue. This is the most common type, around 20%. It's caused by issue like stroke or vascular injuries. The key symptom here is the impaired planning or judgment, not just memory loss. The plan and judgment usually occur later in Alzheimer, but it is very early in sign in the vascular dementia. And the brain imaging show vascular lesion feature in the imaging features. Neurodegenerative dementia, this is compared to the disorders like Parkinson's disease that mainly present with the motor symptoms, and the patient develop dementia later on. And then there is a fixed diseases, which mainly in the form of the temporal dementia and can lead to behavioral and language deficit. And we have the Huntington disease, and this is the inherited type of movement disorder, and it also combines with cognitive deficit. The brain change in the neurodegenerative dementia, it includes what we call tau inclusion, fixed body, and there is also the alpha synuclein feature in the disability slides. Also, there is HIV-associated dementia seen in advanced acquired immunodeficiency syndrome. This early sign presents poor attention, slow thinking, and memory issue, and the late sign can present in form of psychosis, incontinence, or gait issue. This type of dementia also can be called AIDS dementia complex. The normal pressure hydrocephalus, it has a classic triad of gait disturbance, dementia, and incontinence, and usually is caused by excessive of the cerebrospinal fluid, which is treated by shunt surgery to redirect the pathway of the excess cerebrospinal fluid, and it's often reversible. And then we have the nutritional dementia that present in form of the Wernicke-Korsakoff syndrome that mainly caused by thiamine or vitamin B1 deficiency, often seen in the alcohol-related patient. And those patients present with severe memory impairment, relatively intact social skills. So the main deficit here in the memory function. It also can be caused by other deficiencies like vitamin B12 and folate deficiency, because those vitamin interaction each other and like synergize the absorption of each other. But the thiamine is the main vitamin that can lead to dementia. Also, we have metabolic and inflammatory dementia. This occurs due to metabolic issues such as in the thyroid gland or parathyroid gland, and in the liver disorder or Cushing syndrome that caused by excessive ACTH from the adrenal gland. And also it can be caused by inflammatory issues like multiple sclerosis, vasculitis, or collagen vascular disease. Dementia also, as we mentioned earlier, it can be caused by trauma or tumors. Trauma, mainly the chronic head injuries, and there is form of dementia called dementia pugilistica that also caused by the severe head injury. The symptoms include tremors, slowness, and gait unsteadiness, and also there is behavioral change in the form of rage. The tumors are mainly in the frontal lobe. Also, it can be in the third ventricle or corpus callosum in the brain. This is can mimic or cause dementia. So now we are going to talk about the differential diagnosis of dementia. Usually the 3Ds, because they are similar to each other, but they are like distinctive feature for each one. We have the delirium and depression. So in the form of the onset, the delirium usually sudden or acute onset, while dementia is more gradual and depression have a variable presentation. The cause in the delirium is fluctuation, and while in the dementia is more progressive in nature, and in depression in episodic it can come and go. In the delirium, there is like increase in the fluctuation, and but in the dementia, the fluctuation is minimal, while in the depression is also variable. Regarding the attention is impaired early in the delirium, while it is later in dementia, and it is usually intact in depression. In the memory component, the delirium affects the short-term memory, and in the dementia, it affects mainly the recent and the remote memory. While in the depression, the change in the memory is usually subjective complaint by the patient. Regarding the consciousness, there is alter of the consciousness in the delirium and also in the dementia. It is clear earlier and also in the dementia. So it affects all three diseases. In the orientation, there is impaired orientation in the delirium, but the dementia usually have intact orientation, like for the time and place, and also it is intact on the depression. Regarding the speech, the patient with delirium has incoherent and disorganized speech, while the dementia patient have issue in finding like the appropriate word, but his speech is not necessarily incoherent or disorganized. While in depression, the speech is reduced or slow. Regarding the hallucination and delusion, delusion is commonly in the delirium, usually as a visual hallucination, usually informs the visual hallucination, and delusion might be present. But delusion, it is more common in depression, and dementia patients sometimes can present with hallucination and sometimes can present with delusion. Regarding the psychomotor symptom, delirium patient has agitation and retardation, while the dementia patient have behavioral change in form of like walking or wandering, while the depression patient is slowed or agitated. It can present with either presentation feature. Regarding the sleep disturbances, it increases in the delirium, and usually the dementia patient has fragmented speech, while the depression patient has difficulty in falling into sleep, which is insomnia or hypersomnia. In the thought process, it is disorganized in the delirium patient and in overshift in the dementia patient, and also there is a negative thinking mainly associated with the depression patient. The reversibility, the delirium usually is reversible by treating the underlying causes, and dementia usually often irreversible because it's caused by neurodegenerative issue or Alzheimer's disease that is usually irreversible, while depression also reversible with appropriate treatment and medication. So the diagnostic approach to dementia mainly consists of the history taking, the physical examination, and then the imaging and laboratory studies. History gathering, we ask the patient and obtain information from reliable informant. We ask him about the onset of progression and nature of the symptom and his medical and medication history, substance abuse history, and also his living condition. We also perform physical examination. We assess his neurological, mental, and functional status, and we use both observation and informant input. And we consider detailed neuropsychological testing if required. And then we can go for imaging studies. We use imaging study to rule out the structural brain causes and assess the brain change, such as the use of MRI. This is the preferred modality in general neurodegenerative disorder. Also, we can use CT scan in conditions like the vascular dementia, and also we can cause form of scanning called SPECT scan and PET scan, and this is helpful mainly for identifying conditions such as Alzheimer's disease. Also, we have laboratory testing, like to detect the reversible causes, like the infection. We order the CBC, and to see the inflammation, we do the exercise sedimentation rate, and also we can check the thyroid function test for the metabolic causes and vitamin B12 deficiency, and the liver function test, and also we can check other things like electrolyte, blood urea nitrogen, and creatinine to assess the function of the kidney and the overall metabolic imbalance. Also, we perform toxicology screen to rule out intoxication or the withdrawal symptom of medication. We can order HIV test to diagnose HIV-associated dementia. We can perform the anti-nuclear antibodies to check for the autoimmune diseases such as SLP. And we can also perform lead tests for the toxicity caused by heavy metal. And lastly, we can do also the lumbar puncture test to check for infection, inflammation, or other specific protein, such as that suspected by prion disease caused by Creutzfeldt-Jakob infection. To confirm the diagnosis, definitive diagnosis is often only possible through the brain biopsy, which is rarely performed because it's difficult and associated with many complications. Also, mainly during the autopsy, which confirms the pathological feature after the patient already present lately while he's dead. So regarding the cognitive assessment, there are multiple cognitive tests that we can perform. First, we have mini-COG, which is a 5-point assessment to assess the visual spatial skill, executive function, and the recall function. And also we have what we call SLUMS, the St. Louis University Mental State Examination, which is a 30-point scale that assesses the orientation, attention, recall, and the executive function. And also we have the Montreal Cognitive Assessment, which assesses mainly the naming, the verbal fluency, the abstraction, and the memory function. And here we have also the mini mental state examination, which is most widely used, that assess the attention, the registration, the language, and visual skills. Also, there is what we call function informant based and is effective mainly in the home safety and the daily living condition and the memory function. The benefit of early diagnosis. The early diagnosis, it is beneficial because it increases the awareness and understanding of the condition, also enable timely treatment to reduce the burden of symptoms. It also facilitates the connection to support system and caregiver networks and provide access to important resources and services. It can open the path to plan future care and allow for completion of the legal preparation. Also, it can empower individuals and families to make informed decisions. So the earlier the diagnosis, the more is beneficial to the patient. Here is some form of the preventative measure for dementia, such as limit alcohol intake, exercise regularly, also engage in your brain, like stimulating your brain with thinking and other brain stimulating activity, and also try to be more socialized and to reduce the burden of the social isolation. So, in summary, dementia, as we said, is not a single disease, rather a collection of the symptoms. It has a multiple risk, but mainly caused due to advance in the age, and then there is a genetic interference. It is important to identify early in order to plan, understand, and manage and support the patient appropriately. There is also drug treatment, but currently just limited to relief of the symptoms rather than treat the dementia itself. But mainly it is center our lifestyle thing to reduce the risk and maximize the well-being of the patient. So thank you, and my teammate, Dr. Abdullah, will continue with you with the treatment and planning.
Thank you, Dr. Asim. Dr. Abdullah, if you are here, you can start when you are ready.
Assalamu alaikum. Yes.
وعليكم السلام ورحمة الله وبركاته.
Bye. Okay, thank you, Dr. Asim. Now I'll share my moment. 1 second.
Take your time.
Is it visible now?
Yes, yes, it is visible and clear.
Okay.
I think we see your screen, but it's not the
Okay.
PowerPoint. Have you? Yeah, now.
Yes, now.
Now we
It's
can
visible?
see.
Okay.
Yes, of course, yeah.
Thank you,
You
Dr.
can
Asim, for
start.
this presentation. Okay. Now I'll continue what my colleague says about the dementia, and I will start with the staging. So, as my colleague said, the staging of dementia comprises of a lot of ones. The first one is stage one says no cognitive impairment. It is unimpaired individuals experience no memory problems, and none is evident to healthcare professionals during a medical interview. Stage two, very mild cognitive decline. Individuals at this stage feel as if they have memory lapses, especially in forgetting familiar words or names or the location of keys, eyeglasses, or other everyday objects. However, these problems are not evident during a medical examination or apparent to a friend, family, or co-workers. So to the stage three, it's a mild cognitive decline. Early stage Alzheimer's disease can be diagnosed in some, but not all, individuals. Friends, families, or coworkers begin to notice different deficiencies. Problems with memory or concentration may be measurable in clinical testing or discernible during a detailed medical interview. Stage 4, moderate cognitive decline. It's a mild or early stage of an Alzheimer's disease starting from stage 4. At this stage, a careful medical interview detects clear-cut deficiencies. The affected individual may seem subdued and withdrawn, especially in socially or mentally challenging situations. Continuing to stage 5, it's a moderately severe cognitive decline. It has major gaps in memory and deficits in cognitive function emerge. Some assistance with day-to-day activities becomes essential. On stage 6, severe cognitive decline. Memory difficulties continue to worsen, significant personality changes may emerge, and affected individuals need extensive help with customary daily activities. Stage 7, very severe cognitive decline. It's the severe or the late stage Alzheimer's disease. This is the final stage of the disease when individuals lose the ability to respond to their environment, to speak, and ultimately to control movement. Now we're going to discuss the treatment. The primary goal of treatment. The geriatricians should be able to manage dementia-related cognitive, behavioral, and psychosocial issues. The primary treatment goals for patients with dementia are to enhance quality of life and maximize functional performance by improving or stabilizing cognition, mood, and behavior. The non-pharmacological management. We're going to start with the cognitive training, supportive individual and group therapy, physical and mental activity, family and caregiver education and support, attention to safety, like needing for supervision, wandering, driving, etc. So, continuing, the environmental modification also, like supportive strategies such as clocks, calendars, to-do lists, visual clues, simple and compassionate communication style. Structure activities to match patient abilities, like for example, the wheelchairs, as a cane or anything that in terms of disability, you can help him with that. Now we're going to discuss the pharmacological management. Treatment should be individualized. So that means if you have like 10 patients with Alzheimer's disease, it doesn't mean that you're going to treat them with the same pharmacological treatment. Cholinesterase inhibitors is one class to treat with. For example, donepezil, rivastigmine, and galantamine. Also, we have memantine and other cognitive enhancers and antidepressants and psychoactive medication. We're going to discuss each one. Cholinesterase inhibitors, they are used to slow breakdown of acetylcholine, because we know cholinesterase is an enzyme that breaks acetylcholine. So the inhibitors of those enzymes will cause a slow breakage for the acetylcholine. Clinical trials demonstrate modest delay in cognitive decline compared with placebo in Alzheimer's disease. GI side effects are common, but are mitigated by slow titration curve and the maximum dosing. The maximum dosing of donepezil, which is 23 milligrams per day, creates significant side effect without evidence of improving global function. There is also no evidence of difference in efficacy among drugs. Continuing, cholinesterase inhibitors, they are used in other types of dementia, but in the widespread use in the vascular dementia, precisely, they are not recommended. And also attention and behavioral disturbances in Lewy body dementia can benefit from those kind of treatment. Rivastigmine is FDA approved for mild to moderate dementia in Parkinson dementia. And the treatment in frontotemporal dementia may worsen agitation. Continuing to the next drug, we have memantine. Its neuroprotective efficacy is to reduce glutamate-mediated excitotoxicity. The modest benefit in cognition and the daily, it has like a modest benefit in cognition, daily living activities, and behavior in Alzheimer's disease. It has limited effect on cognition and no evidence to support widespread use in vascular dementia. It is FDA approved for moderate to severe Alzheimer's disease, and common adverse events, it's constipation, dizziness, and headaches. We have also continuing the other cognitive enhancers. For example, vitamin E, alpha tocopherol, may lower rate of functional decline, but no evidence of cognitive improvement in Alzheimer's disease. So the earlier, the better to the patient. The clinical efficacy and safety of vitamin E has yet to be fully established. We also have selegiline. It may lower rates of functional decline, but no evidence of cognitive improvement in AD. We have also ginkgo biloba. It's used widely among students who wants to improve their mental clarity or even like improving their memory. But in this kind of context, it offers no benefit in slowing cognitive decline in MCI. Now we're gonna go to the symptom management. We need to start with the psychoactive medications. Behavioral disturbances best managed non-pharmacologically. For example, reducing overstimulation or environmental modification. When meds are required, target symptoms should be identified and therapy selected accordingly. Like we said, every patient needs to be individualized in terms of pharmacological therapies. Now, the next class is antidepressant for depressed moods and low appetite, insomnia, fatigue, irritability, and agitation. Also, a trial of high-dose citalopram demonstrated significant improvements in behavior, but also resulted in worsened cognition and QT prolongation. And also, as a caution, false and anticholinergic effects that may worsen confusion, for example, paroxetine. Continuing the symptom management, we have the first and second generation antipsychotics. It has limited evidence of efficacy and increased risk of all-cause mortality in dementia. It should be used with caution in targeting delusions, hallucinations, paranoia, and irritability, and frequent attempts to taper off. Valproic acid and carbamazepine, they are a possible option, but with limited evidence and increased risk of mortality. Because, for example, valproate has a tendency to make a patient vomit. It has make the patient has a tendency to be anorexic also, and you don't want that in a geriatric patient to not eat for a prolonged time. Also, it has for example, the pancreatitis and rash. So yeah, it's increased risk for mortality overall. And benzodiazepine and anticholinergic medication should be avoided. And to the resources in managing dementia. Specialist referral to, first, geriatric psychiatrist. Secondly, to a neurologist. than to a neuropsychologist. Also, social workers, physical therapists, nurse, and pharmacists. Also, we have now also to help a patient with the to manage dementia. We have also the attorney for will, conservatorship, estate planning. Basically, it's just like a managing the legal welfare, if you could say, to the patient. Also, about community, we have neighbors and friends, aging and mental health networks, adult daycare, respite care, home health agency. With organizations, we have the Alzheimer's Association and area agencies on aging and councils on aging. We have services. We have services like Meals on Wheels for food delivery and senior citizen centers. ChoosingWiley.org, they say, don't prescribe cholinesterase inhibitors for dementia without periodic assessment for perceived cognitive benefits and adverse gastrointestinal effects. Don't use antipsychotics as first choice to treat behavioral and psychological symptoms of dementia. And to summarize what I said, we say dementia is common in older adults, but is not an inherent part of aging. It is not an inherent part of aging. Alzheimer's disease is the most common type of dementia, followed by vascular dementia and dementia with Lewy body. Evaluation includes history with informant, physical, and functional assessment, focus labs, and possibly brain imaging. Primary treatment goals is to enhance quality of life and maximize function by improving cognition, mood, and behavior. Treatment may involve both medication and non-pharmacological interventions. Community resources should be used to support patients, family, caregivers. We have 3 cases at last. The problem says a 75-year-old man is brought to the office by his wife because he has had progressive cognitive and behavioral decline for the last 3 years. The wife says that his memory, attention, and organizational abilities have declined, such that his daily function is impaired. The patient says that his sense of smell has decreased, and he has had progressive weight loss, and he has acted out his dreams for many years. More recently, he has behavioral disturbances that is worse at night, with frequent delusions and intermittent hallucinations. So, which one of the following clinical features is most useful for differentiating dementia with Lewy bodies from Alzheimer's disease? We have psychosis, hyposmia, and memory impairment, and rapid eye movement or REM sleep behavior disorder, which is the REM sleep behavior disorder. A second case, we have an 80-year-old man is seen for his annual wellness visit. His wife says that his thinking has slowed in the last 2 to 3 years, and he does not focus as well as previously. Reminders help, but he can no longer manage household finances or organize his medications without assistance. He has insight into his deficits, and in his history, we have hypertension, diabetes mellitus, CAD, and prior stroke. In examination, he has mild left facial droop, mild left arm spasticity, and pronator drift without overt weakness or hemiparetic gait. And lab finding, we have creatinine of 0.8, hemoglobin of 12.8, and hemoglobin A1C was 7.8%, with thyroid stimulation hormone is 2.2, and vitamin B12 is 580, and HDL cholesterol is 62 milligrams, and LDL cholesterol is 112. MRI of the brain says moderate bilateral white matter hyperintensities on T2 flare sequences, with evidence of several chronic lacunar infarctions. So, which one of the following is most likely to improve cognitive outcomes over time? Like the ones we said before, we have exercise program, we have omega-3 fatty acid supplementation, and cholinesterase inhibitors and statin. And the answer is exercise programs. Now for the third case. A 76-year-old woman comes to the office to establish care. She has had progressive cognitive and behavioral decline over several years. The patient cannot provide sufficient information. Her family describes impaired function, and they are not sure how much is due to decline in cognition and how much is and how much to lose and how much to loss of interest in activity. She has no other symptoms of depression, and she has no delusions or hallucinations. On examination, she displays poor memory and concentration. Language function seems intact. The patient has limited awareness of her deficits. Testing is limited by impulsivity. Laboratory findings are unremarkable. And on MRI of the brain, we have mild white matter changes and moderate diffuse atrophy. There is no evidence of stroke or mass lesion. So which one of the following imaging modalities should be done next to establish the diagnosis? We have the dopamine transporter single photon emission computed tomography, or SPECT. We have also the FDG PET scan, the precision imaging tomography for fluorodeoxyglucose, and magnetic resonance spectrography, and regional cerebral blood flow SPECT. And the answer is the fluorodeoxyglucose precision emission tomography, or FDG PET scan. So thank you very much for listening. I hope it was well and clear.
Thank you both for the great presentation. Does anyone have any question about this topic? Okay, I do have a question actually about the staging. It was interesting. I mean, like, why they're considering stage one, since it is like the patient has normal cognitive function. Maybe Dr. Nader can explain better for us. Like, I did Google search. They said it's like a basic, to be a basic for the patient, or like, yeah.
So it's interesting. Thank you so much for raising the question, because I was wondering when we started about this, talking about this topic. In other conditions, if there is risk factors, and in dementia we have some risk factors, let's say family history or genetics, maybe this will put them at stage one. They don't have symptoms, but they may carry the what's called the genes, and there are some genetic testing in the market that might also indicate some risk in certain families. So I suspect this might be the case.
Yeah, thank you. Actually, I found it in many, like, when I Google it, I found like in many websites, they start with stage one, and it's like there is no cognitive function impairment. So I'm just like curious. Thank you for the explanation. Thank you, Dr. Nader. So, yeah.
It's the
Now,
same like when you look at congestive heart failure, some of the classification of that is if the patient has hypertension, then they will be stage one congestive heart failure, even though they don't have symptoms. So for me, all my patients now, as they get older, they have hypertension. I can label them as also congestive heart failure patients. Thank you.
Thank you, Dr. Nader, for this explanation. Thank you very much. Now let's
Any
hear
questions?
yeah. Any other questions? Yeah.
No, finish. I'll leave you with my colleagues.
Yep. Thank
Thanks
you
for
very
listening.
much. Thank you very much, Dr. Abdullah and Dr. Asim, for this great presentation. Now let's hear from Dr. Alhaj, who will presenting introduction of statistic. This session will cover the basic and essential statistic concept. Dr. Amuna, you can start when you are ready.
So, hello everyone. My name is Alhaj, and I will now present my presentation. Give me a second to share my screen.
Yeah, take your time.
Are you able to see my screen right now?
Yes.
Okay, so hello again, everyone. Today I will guide you through a brief introduction to the basic statistical concept. Our objective for today is to understand the basics of statistics, to differentiate between descriptive and inferential statistics, to recognize the different type of data and level of measurement, and to identify the key variables in research, and choosing the appropriate statistical test for your data to be able to apply this knowledge into practical examples. So in the start, what is statistics and why it's important in research? It's the science of collecting, analyzing, interpreting, and presenting data. And it will help us to make sense of complex concepts and information to draw meaningful conclusion from data set. In research, it's essential to understand trends, test hypotheses, and make informed decisions. So we have two types of statistics. We have descriptive and inferential statistics. The descriptive ones summarize and organize the characteristic of data sets, such as averages, variability, and distribution, and we will expand on this in a while. Inferential statistics use the sample data to make generalization and prediction about population. For example, if we have a study of effect of drug A and A1C level in diabetic patient, if we found a significant difference between the control and the experiment group, let's say we are reporting the average A1C between the control group and the average A1C in the experimental group. This average A1C level is inferential statistics, in fact. So other type of data we need to know in order to have a correct set and categorization to our data set is the qualitative and quantitative data. Qualitative are also known as categorical data. This is gender, blood type, and pain scales. The quantitative data are numerical data, such as weight and height. Other way to describe our data is to divide them into independent and dependent variables. The independent variables are the variable that researcher manipulate or control to have an experiment, to observe an effect. And it's the cause and effect relationship. And its value does not depend on other variables in the study. For example, if we have a study, the effect of different amount of sleep in test performance, the amount of sleep is the independent variable. And the dependent variables are the outcome or the response that measure in an experiment, and it is the effect side. So it's mainly depend on the independent variable. In our same example, the amount of sleep is the independent variable, and the test score is going to be the dependent variable. So we have also the concept of level measurement or scale of measurement, and it's referred to how precisely a variable recorded or categorized in a data set. It's very crucial to understand your data type for selecting your right statistical test. We have four types of level of measurement. We have the nominal data. This is categories with no order, such as gender and ethnicity. We have ordinal data, such as ordered categories, such as educational level, rank, etc. We also have interval, and this is for numerical scales with equal intervals with no true zeros, such as temperature is Celsius degree. The last level of measurement is ratio, and this is numerical scales with true zeros, such as age and height. So let's say we categorized our data and we identified our variable, and now we are ready to pick one of the statistical tests by using some of the statistical tool analytic so as to get or draw a meaningful result. We need to know what is the right statistical test according to our data. So let's say, for example, we have the t-test. This is for numerical or continuous data, and we use it to compare the mean between two groups. For example, if we are comparing the blood pressure between drug A and drug B. We also have a ANOVA test, and this is also for numerical data, but when we are comparing more than two groups. Let's say we are comparing the mean weight between 3 groups following 3 different diets. We also have the chi-square and Fisher exact. They have the same usability, but the chi-square for the large sample size and the Fisher exact for a small sample size. They are measuring the categorical or proportion data. Also, we have the percent correlation and the logistic regression. Regarding the percent correlation or the correlation coefficient, which also denoted as R, this measured the strength and direction of the linear relationship between 2 continuous variables. Let's say we are measuring, or we're saying that taller people tend to weigh more. And this can be called as a positive relationship or positive correlation. And usually it's scaling between +1 for positive correlation to -1 for negative correlation. And the closer your values to the 1 is the stronger your correlation. The last test we're talking about today is logistic regression. And logistic regression is a statistical method used to predict the probability of binary outcome, such as yes or no, or success and failure. So unlike the linear regression, which predict the continuous outcome, logistic regression measures the odds or the probability of the outcome. So to ensure that the prediction is always falling between 0 to 1. For example, in medicine, we use it to predict whether an improvement or no improvement will occur after a specific intervention, or to predict a disease from age or BMI. All of those are used to visualize the data. We're using different analytic tools such as the SPSS, the SAS, the Stata, the R, the Python. Those will help you to analyze your data. So let's say we have now our data ready, we analyze it, and we want to draw a conclusion. There is some concept we need to grasp on in order to be able to interpret and read our data. The first thing is the central tendency. It's a fundamental statistical concept that identifies the center or typical value of a data set. It provides a single value that best represents the entire distribution of a data point. And there are 3 things to be read within the central tendency. We have the mean, the median, and the mode. The mean is the average of all data points, and it's calculated by summing all the values and dividing them by the number of distribution. And the mean is a value that is super sensitive to the outliers and most appropriate for the data that's symmetrically distributed and continuous. We also have the median, which is the middle value of a data set that arranged in an ascending or descending manner. The last one is the mode, and it's most frequently occurring. It is the most frequent data or value that occur. And your data can have no mode. It can have 2 modes or multiple modes. The other concept we're going to talk about is the dispersion or the measure of variability. And dispersion or the variability describe how spread out or scattered your data point around the central value. So while central tendency tells us where our data cluster, dispersion quantify the variability within our data. So providing more like a fuller picture or bigger picture of our data set. And also we have different measurement for the dispersion. We have the range, the interquartile range, the variance, and the standard deviation. For the range, it is the simplest measure of dispersion, and it's calculated as the difference between the highest and the lowest value, but it's sensitive to outliers, and at the same time, it's not reflect the true distribution of values between the extremes. The other measure is the interquartile range, and basically, we measure the middle 50% of our data, and we calculate it by having the difference between the 4th quartile or the 3rd quartile, and the 1st quartile. And it's less affected by the outlier and skewed data. The variance is the average of square difference for each data point, and it quantifies the overall spread of data, but the variance is expressed in squared meters. So it's not the same unit we measured our data. So it can be difficult to interpret directly. That's why we are using the standard deviation, which is the square root of a variance and express variability within the same unit of our data. And it represents the average distance of data points from the mean. And it's widely described in the normally distributed data. And it's read as 1 standard deviation below or above the mean, 2 standard deviation below and above the mean, and 3 standard deviation below and above the mean. So we talked about the distribution of data and how it affects the way we're reading our data. So the distribution describe how data are spread and arranged across possible values, and understanding the underlying distribution is crucial for selecting the appropriate test and interpreting your result as well. So we have the normal distribution, also called the Gaussian or the bell-shaped distribution, which most of the data point cluster around the mean. In this distribution, the mean, mode, and median are equal to each other, and many of statistical tests assuming normality in its mathematical properties and prevalence. The other distribution is the uniform distribution, which is shown here, and this is showing a continuous probability of distribution in which all value within a specific interval are equal to each other. The skewed distribution is one of the data, it's one which the data are not symmetrically distributed around the mean. So when the long tail on the right, the higher values, it's called right skewed or positively skewed data. And if the tail into the left, it's called the negative or left skewed data. And in this skewed data, the median is always in positive or right skewed data, the mean is typically greater than the median, and the mode will always be in the middle, and vice versa. In the left skewed data, the mean is the less. And lastly, we have the bimodal distribution and its probability with 2 distinct mode or peaks. And this means that your data have 2 different values or taken from 2 different population or processes. And it's also good for the readability of specific prevalence of disease or specific prevalence of any specific phenomena. So let's say we are now having our data set and we are able to read them. It's also very important to know the concept of probability and hypothesis testing. The probability is originally a branch of math or statistic that quantify how likely an event to occur. And it's expressed in numbers between 0 and 1, where 0 indicates an impossible event and 1 indicates a certain event. Probability can also be represented by percentage, let's say between 0% to 100%. So the hypothesis testing is another concept, which is a statistical method used to make inference about a population or a sample data. It helps us to determine whether there is enough evidence to support a specific claim or hypothesis. So the key element in hypothesis testing is what's called the null hypothesis or H0 and the alternative hypothesis or H1. So the null hypothesis is a statement that there is no effect or no difference. So it represents the default or the status quo assumption. The alternative hypothesis is the statement you want to test in your research or your dissertation, and it represents an effect, a difference, or a relationship. So after you have your H1 and H0 ready, you have 2 outcomes after you're testing your hypothesis. The first one is to stating that there is an effect or a difference when one exists. That means you are rejecting H0 in favor of H1. Or the stating that there is no effect or no difference when none exists. So H0 is not rejected. During this outcome, we're facing 2 types of error. We have type 1 or alpha error and type 2, or beta error. Type 1, also called the false positive error, which states that there is an effect or difference when none exists. So that means H0 is incorrectly rejected in favor of H1. And type 2 error is also called as the false negative, stating that there is no effect or difference when one actually exists. Also, there is a fundamental concept called a p-value. It's the probability of assuming that H0 is true, obtaining a result equal or more extreme than what we actually observed. Basically, that you get some of your result by chance. And a small p-value, which is less than 0.05 is a strong evidence that H0 is rejected. So it's in favor of your assumption. Also, we need to know about the confidence interval, and it's a range of value derived from a sample data to estimate where your population or parameter is likely to lie. So it's more like providing an estimate and a measure of uncertainty around that estimate. So the confidence level, it is the probability, let's say the 95% or the 99% that the interval, when calculated repeatedly from different samples, contain the true population parameter. So it reflects the long-term success rate of the method you use to measure your values. Also, we have the point estimate, and it's a single value calculated from the sample data, like sample mean or sample proportion, that serve as the best guess for the population parameter. We also have the margin of error, which is a range around the point estimate that account for sampling variability, and it depends on the standard error and also estimate of the critical value from statistical distribution. So the correct way to interpret the confidence interval, let's say we are interpreting the 95% confident interval, that means we are 95% confident that the true population parameter lie within this interval. That means if we repeated the sampling process many times, 95% of the result intervals will contain the true parameters. Okay. So we have many factors that affecting the confidence interval. First one is the sample size. The larger your sample, the narrower the interval will be. The variability, the greater the variability between your data set, this will widen the interval. And the confidence level, the higher the confidence level is, the wider the interval. So when we are using the interval, we use it to estimate population parameters such as mean, proportion, regression coefficients, and to assess the precision of an estimate. So whenever we get a smaller interval, that indicates greater precision of our data. And also to compare groups, if we have an overlap between two intervals, that means there is no difference. While if we got no overlap between our data set, that will mean a significant difference between them. So in summary, statistics is essential for our research. It's very important to understand your data type and select the appropriate statistical test. It's very important to grasp the concepts of statistics to be able to interpret your data correctly and carefully. And the most important thing is to consult expert for complex analysis. It can be even harder than that sometimes. And this is the reference we use for today. And thank you. If anyone got a question, you can ask directly or write it on the chat box. Thank you.
Thank you, Dr. Mona. Thank you very much for this insightful presentation. Of course, understanding this tool is a fundamental to interpreting that medical research and give a big picture about the research and the studies that is being going on. Is there any question for Dr. Mona? Is there any question? If there is no question, we can move on to OpenAI, which is the pioneer platform in artificial intelligence and machine learning, presented by Dr. Noura. Dr. Noura, if you are ready, you can start now, please.
Assalamu alaikum. Hello, everyone. My name is Noura Mohamed. I'm a member of the Pink team. Nice to meet you all. I'm now going to share my screen. I have a problem with sharing my screen.
Just
Yeah, I found it. Thank you.
Take your time and you can do it. Yeah. Now it's clear and visible to us. We cannot hear you, Dr. Noura. If you are speaking, we cannot hear you.
Just a second.
Okay.
Can you hear me?
Yes, of course. Now we can hear you. Yeah.
Okay, so today I'm going to talk about OpenAI. First of all, the evolution of OpenAI. OpenAI was founded in late 2015 and has rapidly emerged as pioneering force in artificial intelligence research and deployment. The company was established with the ambitious goal of advancing artificial general intelligence in a way that benefits humanity collectively rather than serving a narrow interest, which is the main goal of the AI. The technologies are increasingly transforming how we work, create, and solve problems across the millions field. So what is OpenAI mission and vision? They have three main missions, which is beneficial AGI, safety first, broad access. So OpenAI core mission revolves around ensuring that artificial general intelligence benefits all humanity rather than serving a narrow interest, as we mentioned before. This vision emphasizes the development of safe and beneficial AI systems, regardless of who built them first. The organization champions transparently its research, prioritizing safety in its development process, and consider the broad societal impact of its technologies. This approach reflects a commitment to responsible AI advancement that balance innovation with ethical consideration. And now the AI has a unique structure. OpenAI operates through an innovative hybrid model that combines a non-profit governance with capped profit subsidiary. This distinctive structure enables the organization to attract necessary investment and talent while maintaining its commitment to development AGI that benefits humanity proudly. Following the recent structure 2025 restructuring, the nonprofit board retained final control over major decisions, ensuring long-term alignment with the original mission. This balanced approach represents a novel solution to the challenge of pursuing ambitious AI research that serve the public good while remaining financially sustainable. So it has so many platforms, but the main platform of the OpenAI has been an impressive suite of generative AI technologies that span language vision and code generation capabilities. First, GPT models, advanced language models capable of understanding and generating human-like text across various domains and applications. Example for it, the most famous one, ChatGPT Conversation AI, handle complex language tasks involving capabilities with each iterations. The DALL-E or DALLE, groundbreaking image generation system that create original visuals from textual descriptions, transform text into details image, support creative expression, demonstrate multimodal capabilities. Codex, a specialized module that translate natural language into functional code across multiple programs language. For example, the most famous example for it is Power GitHub Copilot, assist developer with coding tasks, accelerate software development. So what is the impact of AI on real world? OpenAI's technologies are driving transformation across numerous sectors, facilitating automation of routine tasks, enhancing productivity, and enabling new forms of animations. From education tools that personalize learning experience to business applications that streamline operations, these AI systems are reshaping how organizations function. Through strategic partnership and open research sharing, OpenAI is also contributing to collective efforts addressing global challenges. This collaborative approach amplifies the positive impact of AI advance while fostering an ecosystem of responsible development. And now, for us, for the most of us as a doctor, AI in medicine. What is the AI impact in medicine? In the medical field, OpenAI technologies are very important in healthcare delivery through intelligent assisting system. AI-powered diagnostic tool are enabling clinicians to identify condition with greater speed and accuracy, while medical chatbots are improving patient access to reliable health information and initial assessments. The ability of AI to analyze massive clinical data sets is particularly valuable for chronic disease management, where pattern recognition can predict complications before they manifest. Additionally, these technologies are accelerating the drug discovery process and streamlining clinical trials, potentially bringing life-saving treatment to patients more quickly. So, future direction and challenges of OpenAI. As OpenAI continue to do advance capabilities, the organization faces significant challenges related to safety, ethics, and alignments, which is the main mission and vision of the AI. The research increasingly focus on ensuring AI system reliability, understanding, and follow human intentions, even as these systems become more sophisticated and autonomous. The commitment to transparency and responsible deployment remains central of OpenAI approach. With this consideration of potential societal impact guiding development decision, this forward-looking strategy aims to prepare for the broader integration of AGI into society while maintaining associated risks. Finally, shaping AI future for humanity. OpenAI represents distinctive approach to AI development that balance cutting-edge innovation with safety, consideration, and social benefits. Their technologies are already transforming numerous industry, from healthcare and education to create production and scientific research. As we look into the future, OpenAI commitment to responsible AI advancement offers a promising framework for harnessing these powerful technologies in serving humanity's greatest challenges. The journey toward beneficial AGI continue with each breakthrough bringing new opportunities and responsibilities that will shape the technology's landscape for generations to come. And this is what all we have for the OpenAI for today. So if there are any questions, please go ahead.
Thank you, Dr. Noura, for the interesting and insightful talk. Is there any question for Dr. Noura regarding this presentation or any comment?
Hello, can you hear me?
Yes.
Hi, my name is Moram Abdelrahman, and I was supposed to present this topic, I think, but it seems like there was miscommunication or something.
Yeah, I think
my presentation was mainly focusing. Oh, yeah.
Yeah, I'm sorry. Actually, I have update the app many times, but it doesn't. I don't know why it cannot be saved the information. And we start presentation in about a month ago. So, but you can do that in future, inshallah, Dr.
Ah,
Aman.
no
Sorry
problem.
for the miscommunication. And if I wish you could,
No problem at all.
you have. Contact me before that so I can like the even what each topic that can be presented by more than one person. So if you just contact me, I can at the time before this time. So you can that you have time to arrange with Dr. Noura and present this topic together. But you can also, if you have your PowerPoint ready, I mean, like you can upload it to the app, and so everyone can have time to look at your presentation. Thank you for your contribution. Is there any question for Dr. Noura, or now we have also Dr. Moram about the OpenAI? If you have any comment regarding the OpenAI or any questions, you can ask Dr. Noura or Dr. Moram as she already prepared for this task. Okay, if there is no, yeah, go ahead. Yeah.
I'd like to thank you all and thanks for the great presentation. I would like to ask Dr. Moram, do you have a different aspect or different view, different information in your presentation about AI that was not covered by the presenter?
Yeah, that's a good idea. If you have something different or like a new information that wasn't mentioned, yeah, you can go ahead and share it with us.
Oh yeah. My presentation mainly focused on AI tools and how to use them in daily practice, in learning and education.
Why don't you present them if you are ready?
Oh yeah, I'm ready. I can present it now if you'd like to.
Yes, please go ahead. Thank you.
Okay, thank you. Just a second. Okay. Can you see my screen?
No, yeah, I think now we can see.
Can you see it
Yeah,
now or?
yeah.
Okay, just a second. What about now?
Yes, now we can see it.
Okay, that's great. Hello, everyone. My name is Moram Abdelrahman, and I graduated from University of Khartoum, batch 92. We lost a dear colleague yesterday after a long battle with illness. Please keep her in your prayers, and may Allah grant her peace and mercy. I'm truly honored to be here with you today. And this topic, as my colleague presented earlier, is a true inspiration. So let's dive into this fascinating topic, OpenAI. Whether you are preparing for residency, managing clinical responsibilities, or teaching, I promise there's something here for you. So let's explore how we as physicians can use AI to work smarter and learn faster. And I think my colleague also used the same app, Gamma, to prepare her presentation too. So that's a nice coincidence. Okay, why OpenAI? You might be wondering, why should we care about OpenAI? The short answer is it can truly make life easier, from studying for USMLE to handling documentation. OpenAI gives us tools that think, write.
Dr. Moram, sorry, I interrupt you. We cannot see the slide that you're in. You are in the first beginning slide.
Okay.
Maybe just because the connection takes time, or I don't know if you. I mean, but we are still in the first slide.
What about now?
Nothing changed yet.
Nothing changed.
It's
Okay.
OpenAI for physicians, and then your name. Yeah, now I think it's, yeah.
Now you can see it?
Yeah, why OpenAI? Yeah, that's what we can see.
Okay, thank you, Dr. Haifa. Okay. So OpenAI can help us in residency preparation, preparing for the exams, preparing our papers. It also can help us in our everyday work and documentation, in clinical reasoning. So AI can really have a lot of functions that can make our life easier. Before we jump in, let's share what you can expect from this session. We'll keep it simple and practical. First, we'll talk about what OpenAI actually is and why it's becoming such a buzzword in medicine. Then I'll walk you through some of the tools that I personally use to create this presentation, and more importantly, how you can use them in your day-to-day as a physician, whether you are studying, teaching, documenting, or just staying organized. And finally, we will cover how to get started using these tools in a smart, safe, and confident way. My goal today is not just to inform you, but to empower you. I want you to leave here thinking, hey, I can actually use this stuff. So what is OpenAI? As my colleague, Dr. Noura mentioned, it was founded in 2015. Its mission is to ensure it benefits all humanity, and one of the key products that they actually provided are ChatGPT, DALL-E, Codex, and Whisper. What can OpenAI do? It actually can do a lot of functions, such as natural language. It can actually generate human-like content. It also can generate image. You can just type a clinical question or type a prompt, and it can immediately generate an image for you. It can also draw pictures. It can also turn speech into text, transcription, and it also can help with code generation and statistical analysis. The tools that I used for this presentation are actually ChatGPT. It's a brilliant co-writer. It helped me to write this presentation, and then I handled all the information it generated after editing it to Gamma. Gamma actually can both generate a presentation from scratch. You can just write a prompt and it can generate all the slides that you need. And it can also modify the things that you provide. You can provide all the content of your slides, and it can immediately transform it into a presentation with imaging and everything. I also used OpenAI Art to modify the images that I thought wasn't suitable, or the images that I thought had a better replacements for it. Okay. Let's get into the core tools, our main topic today, the core tools and their relevance to physicians. ChatGPT is the superstar of OpenAI, of course. All you need in one medical assistant, you can say that. It's like having a super smart assistant in your pocket. You can use it to summarize study material, generate mnemonics, or simplify complex guidelines. It's incredibly useful also for preparing for exams like USMLE, Step2CK, and OET. Personally, I used it during my final preparation for Step2CK. You know those free 120 questions on the official website with no explanation? I sent in those ones I got wrong, and ChatGPT helped me clarify the core concepts. But here's the thing. 2 out of 7 answers were wrong, with very confident explanation. So it's important to always double check info before from a trusted source. Also, a colleague of mine used OET for writing practice. Used ChatGPT, sorry, for the OET writing practice. She asked for feedback on a referral letter and got detailed feedback and predicted score of 360, which ended up being her exact score on the real exam. And the key to getting that kind of high quality feedback is to use a good prompt. If you wrote something like, "Give me a comprehensive feedback for this referral letter using OET official website criteria." So the more specific and guided your prompt, the better the results you will get. ChatGPT is also amazing for patient and student education. You can adapt explanations for any audience. I even once used it to help me design a course. Of course, you edit the output, but it makes it easier than starting from scratch. And for the writing tasks, like personal statements and even the star summaries, it becomes part of our daily workflow. It helps expand abbreviations, fix formatting, and clean up language fast. You can even...
sorry, Dr. Moram, for the interruption. What you're talking about and the slide is not like the same, so maybe you just have to click the slide when you are back to it. Now we can see the slides wanted. Now it's like the ChatGPT, you and all in one medical assistant.
Yeah.
Yeah, is this the one that okay?
Oh yeah, we are still in the same slide. Thank you, Dr. Haifa. Okay. Okay. Also, can use ChatGPT for mock interviews or clinical reasoning sessions. So ChatGPT actually have a lot of uses. That's why they call it the superstar of AI. Now we'll get into other AI tools that can help us, and I divided them by function, so it's easier for you if you wanted to go through the presentation later on. The AI study tools It can help you with your studying and exam preparation. First, Perplexity AI. It's great for quick lookups, which is perfect when you are reviewing or clarifying concepts. The great thing about it is that it always shows source, so you can trust the information and then dig deeper if needed, unlike ChatGPT. The second tool that can help you with your studying is Sky Space and Site AI. It helps make research papers much more digestible. It's perfect for evidence-based medicine and studying current or staying current with literature. The third tool that can help us with studying is Cloud. It's great for summarizing long documents or organizing your notes. It's especially helpful if you are reviewing lectures or course PDFs. This in regard to AI study tools. Let's move to documentation and writing support. The first tool that we have here is Whisper. It transcribes anything you say, meetings, lectures, and even patient encounters. So it can really help with the documentation. You can use it in your everyday workflow. The second tool here is DocsGPT or Doxinity. And it is like ChatGPT, but tailored for doctors. It can generate patient notes, referrals, and handouts. And the hugest difference between ChatGPT and Doximity is that Doximity is considered to be a safe AI tool that you can put your patient's information here without violating their privacy, unlike ChatGPT. The third documentation tool here is Microsoft Copilot. It brings AI right into Word and Outlook, so it's perfect for writing clinical emails and notes. Moving right to teaching, education, and presentations. The tools here that we have here are DALI, which can generate custom visuals for teaching or explaining things to patients. Our second tool here that we are now using is Gamma, which can help create professional presentations fast. And lastly, of course, ChatGPT. As for clinical reasoning and workflow tools, we have number one here, Glass AI, which can give you diagnostic suggestions and differentials. But of course, we can never rely completely on AI. They can give you suggestions, but at the end, we need your clinical judgment. The second tool here is Otter AI, which is can give you a real life transcription of patients' interviews or meetings. And lastly, of course, Whisper, as we said earlier, is a speech-to-text tool designed to transcribe the clinical discussions accurately and efficiently. So it can be of a great help in your everyday work. It can save you a lot of time. Moving to research and literature review tools. We have first Ryan, which is an AI-assisted tool that helps screening abstracts and full texting during systematic review. It can speed the decision on which studies to include or exclude. Our second tool here is RoboViz. And this AI tool visualizes biases and risks in research data, which is especially useful for meta-analysis and critical appraisal. Our third tool here is Site AI or Skyspace AI that we mentioned earlier, that can summarize research papers, analyze citations, and simplify complex scientific languages to make research easier to understand. And lastly here, we have Perplexity AI, which we mentioned also. It can provide cited sources, so it's great for background research and evidence checks. So those are the 4 AI tools that I chose to put in our presentation today, or AI tools that can help us in research. Lastly, we are going through the AI tools that can help us for productivity. We have first Notion AI, which is great for staying organized. You can use it to plan your study schedule, keep research logs, and collaborative notes. And lastly, of course, ChatGPT plugins, which help structure abstracts, grant applications, draft research ideas, and with built-on logic and reasoning. I left here the links, so you can check them and start using them. Okay, now after we went through the AI tools that can help us in our everyday life, let's get into the ethical considerations and limitations of those tools. Please remember to never share patients' identifiable information into any AI platforms unless it's HIPAA compliant. HIPAA stands for the Health Insurance Portability and Accountability Act. Of course, ChatGPT is not a HIPAA compliant, meaning you shouldn't enter real patient identifiable information into it. Unless OpenAI provides a HIPAA compliant version, we cannot share it currently. Always double check medical content and don't rely on its clinical judgment. It's a tool, not a licensed doctor. So try to think of it as a medical intern. Smart, helpful, but it still needs supervision. And yeah, it doesn't replace your medical expertise. Just remember that. So how to start using OpenAI tools? First, we need to choose the right AI tool. You can check the tools available there, see which functions that you need, and start using the tool that suits what you need the most. Second, sign up for the tool. And there are many AI tools that are available for free. So you can start with that, and then you can choose or use the paid version if you need it, another services. Stay HIPAA safe, never input real patient identifiable data. And so I recommend to start using AI for non-sensitive tasks, such as writing, summarizing, planning, and education. Start simple. You can just ask AI to summarize article or draft a discharge summary, and with time, you'll find yourself able to write more detailed prompts and use it for more complex tasks. Point number 5, integrate with daily workflow. I recommend here that you take a look at your daily workflow and identify which tasks are the most time-consuming. A great way to start using AI is by applying it to time-saving activities, like formatting documents, creating teaching materials, or simplifying complex topics for patients and students. And lastly, stay updated. AI is evolving quickly, so it's important to stay informed. Keep an eye on updates from OpenAI and engage with medical AI communities to discover new tools and applications relevant to your practice. As we close, the most important message is OpenAI tools aren't just for programmers or data scientists. They are practical tools we as a physician can actually use today, from cutting down time on documentation to simplifying how we teach and learn to helping us organize our thoughts. AI can be a powerful ally in our day-to-day practice. It's here to support us, not to replace us. Always remember to use AI responsibly, especially when it comes to patient data and privacy. And medicine is evolving, and AI will absolutely be part of that evolution. By staying curious and open-minded, we can enhance both how we work and how we care for patients. Thank you so much for your time, and I hope this session sparkled some ideas for you. And I'm happy to answer any questions or hear your thoughts. Thank you for the opportunity.
Yeah. Thank you, Dr. Moram, for this insightful and interesting information about the OpenAI. Thank you both, actually, Dr. Muna and Dr. Moram. Now we have 2 point of view about the OpenAI. If you have any questions, any comment about the OpenAI, you can go ahead and ask. If no, we can move to our last presentation, which is about the technology informatics, and will be presented by Dr. Mohamed Hussein and Dr. Mohamed Rashid. Actually, it's this presentation is about, you can say it will be expand what Dr. Moram mentioned earlier. So this presentation, they will focus on electronic health record effectively, how to use it effectively, interpreting data for medical devices and app, staying updated with the new developments in telemedicine and digital health tool. Dr. Mohamed Hussein and Dr. Mohamed Rashid, you can start if you are ready.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. This is Mohamed AlRasheed from Canary Team 1. Is my voice clear?
Yes, your voice.
Okay, just give me 1 minute to share my screen.
Yep, take your time.
Okay. So is it clear, the screen?
Yes, it is. Yep.
Okay, that's good. Just give me 1 minute. So, good evening again, everyone. My name is Mohamed AlRasheed, fresh graduate from Faculty of Medicine, University of Khartoum. Today, with my colleague, Dr. Mohamed Hussein, we'll present you a presentation regarding electronic health record. This presentation was supervised by Dr. Haifa Ramadan. So, to start, what do we exactly mean by electronic health record? Electronic health record is a digital version of the patient paper chart, but it's much more than that. It's a longitudinal electronic record that tracks the patient health information over time. It includes data from multiple encounters and across different care delivery settings, such as hospital, clinics, and even telehealth sessions. So electronic health record provide a more complete and accessible view of the patient care. So electronic health record have a several crucial role in the healthcare system. First, they represent a comprehensive health history of the patient, allowing provider to see the patient pattern, past treatment, and long-term outcome. Secondly, they enhance communication among doctor, nurses, pharmacists, and other healthcare professionals, so everyone can stay on the same page. Third, they can act as a legal document, documenting the care provided to the patient. Fourth, electronic health records are essential for research and education, enabling data analysis and clinical training. Lastly, they support care quality by offering alerts, reminders, and best practice guidelines at the point of care. So what kind of data that is actually stored in electronic health record? At the basic level, you will find patient demographics like name, age, gender, and contact information, medical history of patient, including allergies, chronic illnesses, and past procedures, and a full list of current medication, including any potential drug interactions, and of course, a record of appointment, including both past and upcoming. So this information helps clinicians to make better and safer decisions. Advanced electronic health record system include even more details data, such as admission and nursing notes, charting day-to-day patient status, presenting compliance, diagnosis, and treatment plans, note from nurses, doctors, and pharmacists, lab results and radiology, referral, discharge summaries, and even billing records. So all these components make electronic health records central integrated platform for managing the patient full journey. So having all this data is great, but only if it's used efficiently. So to make the most of electronic health record system, healthcare providers should focus on structured data entry, customization, and proper training and accurate documentation. So structured data entry, as I said, customization, and proper training and accurate documentation. This ensures that the system improves care rather than slowing it down. So structured data entry means using, structured data entry means using drop-down menus, checkboxes, and template, and not just free text. This makes the data easier to research, analyze, and share. Customization also is a key, so as clinician can create templates for common condition or procedures by using hotkeys, and even that they can use voice detection to save time. This balance quality documentation with efficiency. So proper training is absolutely essential. Without it, of course, user may struggle to use the system or make mistake. So ongoing training session, refresher courses, and peer support help maintain proficiency. We also must be careful not to over document, and always, as Dr. Moram said, double check autofill data, which can sometimes lead to errors. So electronic health records are even more powerful when connected to external medical devices and apps, such as wearable devices like smartwatches and home monitor, like glucometer, blood pressure cuffs. And so these tools generate real-time data that can feed directly into the system. So this enable remote monitoring, early detection of problems, and more personalized care of the patient. So some example of these devices include, as I said, wearable like fitness trackers and heart rate monitor, home devices like digital blood pressure monitor and glucose meter, healthcare apps for tracking symptoms, medication, or lifestyle habit. This data adds depth to the context and to the overall clinical picture. Sorry. Coming to the benefit of electronic health record. Electronic health record system bring a lot of benefit, such as faster access to accurate patient information, time efficiency, and thereby freeing up time for direct patient care, improve quality of care with better tracking and fewer errors, and lastly, strong communication, especially across department and care setting, and even among different hospitals for the same patient. So the system move from reactive care to proactive and hopefully preventive care. So some studies showed that electronic health record use may lead to the following: higher quality of care due to better informed decision, and reduce medical error by flagging drugs interaction or incomplete record. So these improve the patient safety, clinical outcome, and the overall satisfaction. So at the organizational level, electronic health record reduce the cost by streamlining operation, eliminating redundancy, and minimizing paperwork. And at the societal level, they support public health, research, epidemiological tracking, and population health management. In the long run, this leads to lower healthcare costs and better health outcome at the national level. So with all these benefits, of course, there will be a drawbacks. So financial challenge, including high initial cost, ongoing updates and maintenance fees, workflow disruption can occur during the transition as the staff adapt to the new system, and privacy concern must be taken seriously because protecting patient data requires strong cybersecurity and ethical handling. So I will stop here, and my colleague Dr. Hussein will continue the presentation regarding the challenge and future trend in the healthcare technology.
Okay.
So, Dr. Hussein, you will share the screen, or I should continue?
Yes.
Okay.
Hi everyone.
Dr. Mohamed, your sound is not clear. Dr. Mohamed, can you hear us? Can you hear me? Your sound is not clear for us.
Okay. Hello, I'm Mohamed Hussein. Can you see my
Just give a moment for Dr. Mohamed Hussein to have a good connection and can resume the presentation.
Dr. Mohamed Rashid, if you have the same slides, maybe you can scroll the slides and Mohamed Hussein, you can just talk. You don't have to
Okay.
share.
Okay, Dr. Nader. I will continue the presentation. There's no problem. Just give me a minute to share my screen. Is the screen is
Hello? Sorry
okay?
for interrupting. Can you hear me now?
Yes, now we can
Yeah.
hear you.
Okay. Is my screen is show it to you?
Yes, we can see your screen as well. Yeah.
Okay. Okay. Hello, everyone. I am Mohamed Hussein. I'm going to continue my colleague talking which about the electronic record. Now I'm going to talk about the challenges and the future trend in healthcare technology. Okay. The first challenges that we may face in our technology, it is technical complexity. By complexity, by adopting systems, we may facing difficulty adapting to the evolving software and hardware system, which maybe some doctors may find some difficulty to use these systems and these apps, and maybe some find some difficult to use it. And also we may have some difficulty with the training needs because we need continuous education is required to keep a pace with the new tools. And also we will have some problems with the data overload, which mean we will dealing with the vast majority of data that need proper organization and dealing with it. And thus all may will find complexity to deal with it. So to solve this problem, we need to do the best practice for informatics use. Firstly, we need to do comprehensive training by using ongoing education tailored to the different users and roles. And also, we need to design a user-centered design, which is an initiative interference that fit clinical workflow. And lastly, we need to use data standardization, which is consist with the format and protocols to improve interoperability. And for the future, maybe we'll find some artificial intelligence in healthcare, which will help us in the diagnosis. As we know, as we see now, AI assist diagnosis and personalized treatment plan for the patient itself. And also AI, and we maybe interrupt or enter with the wearable innovation. Like we can see, next generation device will enable deeper insight and continuous monitoring for the patient vitals and give us a clear view about the prognosis. And lastly, we may use virtual reality, which is immersive training and therapy enhance patient engagement. So now we have key takeaways just to improve our future in electronics. Firstly, we need to master electronic health record use by adopt best practice for seamless patient data management. Secondly, by commitment to learning by staying informed about the emerging tools and updates. Third, we need to know about leverage device data which help us in integrate insight from medical apps of the comprehensive care. And lastly, we need to know about embrace telemedicine, which expand access through the digital consultation. And about the training and user experience, we need to do ongoing education. It is essential for adopting to new digital healthcare tools and workflow integration, which is will be to user-centered design improvement, clinical efficiency, and satisfaction. And lastly, in the future, what will be going the future healthcare technology outlook, as we mentioned before, AI and wearables devices, which is driving personalized care and continuous patient monitoring. And lastly, to provide us with the virtual reality, which is enhanced training and patient engagement through the immersion. And that's all about the health record use. And thank you for listening.
Thank you, Dr. Mohamed Hussein and Dr. Mohamed AlRasheed, for this careful and forward-looking presentation. If there is any question for Dr. Mohamed Hussein or Dr. Mohamed AlRasheed, please feel free to ask. Okay, so of course the healthcare system is continued to fastly growing. Therefore, mastering these tools is essential for delivering high quality patient-centered care. So once again, I would like to thank all you for participation, effort, and collaboration. Your dedication is truly appreciated, and also I want to appreciate Dr. Nader's flexibility in allowing additional presentations. Dr. Nader, you can, finish the meeting.
Thank you so much, Dr. Haifa, and I'd like to thank all the Sorry about that. Thank you all the presenters. And last item in the agenda is the updates. Any questions, any updates, or any ideas, suggestions? Thank you all presenters. Thank you, Dr. Haifa and your team. If no questions, we can adjourn or end the meeting. I'd like to thank all the attendees from today's meeting and those who will watch the recording in the future. Thank you and have a wonderful day. Assalamu alaikum.
جزاك الله خير دكتور نادر، مع السلامة. السلام عليكم.
جزاك الله خير.